Good afternoon, everyone, for this new topic on TransConnect. The topic for today is hepatitis B. I am Dr. Mohit Chaudhary, and I am accompanied with my colleague, Dr. Ashna Gupta, who will be talking about this topic, very important topic of hepatitis B. Hepatitis B, we all know, is endemic to India, and we need to know how to test it, what are the various stages, how we can make it better for the patient by testing the appropriate test here, and also what is the course of the disease. So this will all be covered in this topic on hepatitis B. Over to Dr. Ashna for the same.
Uh, Hello everyone, I'm Dr. Ashna and I will be talking about hepatitis B. The structure of hepatitis B. Hepatitis B virus, it is a member of Hepadna virus family. It is a DNA virus. The structure has an outer envelope and an inner core. It has a partially double-stranded circular DNA with a complete negative strand and an incomplete positive strand. On the surface, it has an antigen which is called as hepatitis B surface antigen. In the core, it has core antigen. This is the incomplete double-stranded DNA which has a partial single strand and a partial double strand, and this is the lipid bilayer membrane which is forming the envelope. And we have hepatitis B E antigen in the pre-core region. This is a diagram again showing the hepatitis B structure. We have outer envelope which has hepatitis B surface antigen. Then in the nucleocapsid core we have hepatitis B core antigen. This is the double-stranded DNA. We have DNA polymerase here. This is called the DAN particle. We have subviral particles and naked nucleocapsid also. Then the envelope protein hepatitis B surface antigen, it has a group specific antigen A and two pairs of type specific antigen DY and WR. The virus is divided into four major serotypes based on this, which is ADR, ADW, AYR and AYW, which is based on the antigenic epitopes which are present on the envelope proteins. There are pleomorphic forms exist including the filamentous and the spherical bodies which lack a core and it can be detected in serum and plasma. These are the separate subviral particles. They are highly immunogenic but non-infectious lipids and proteins which form the hepatitis B surface antigen. Now, transmission of hepatitis B, how it is transmitted. The infected patients which contain the HPV virus, they contain it in blood, saliva, semen, breast milk and other secretions. The individuals with repeated parenteral exposure such as multi-transfused patients like thalassemia, hemophilia, the contaminated inefficiently sterilized medical devices like in dialysis unit with shared equipment, it can be transmitted through vertical transmission from mother to child, and in heterosexual or homosexual contacts it is reported. Now, genetic variants of hepatitis B, the virus is divided into 8 genotypes, A to H, based on the nucleotide sequence variation of the genome. The genotype A is the most common. Knowing this genotype influences the clinical outcomes, the HBeAg seroconversion rates, the mutational patterns in the pre-core and core promoter regions, and response to antiviral therapy. Now, mechanism of hepatitis B infection. First, the hepatitis B virus, it infects the hepatocytes by binding to an NTCP receptor and it then enters into the cytoplasm by endocytosis. Once it is delivered to the once it enters the it delivers to the nucleus, the plus strand DNA is completed by the DNA polymerase and the genome is converted into a covalently closed circular DNA. Then this it acts as a template for transcription of 5 viral RNAs. I will further describe it in this diagram. So the first, the hepatitis B virus, it binds to heparin sulfate which is present on the hepatocyte surface. It attaches loosely to heparin sulfate. Then it attaches, high affinity binding occurs and it attaches to NTCP receptor. Then it enters the hepatocyte by endocytosis. Uh, this is the viral entry. It enters by endocytosis. Then the nucleocapsid is released and the DNA enters into the nucleus. Then this partially double-stranded DNA is converted into a covalently complete circular DNA by the help of host DNA polymerase. Then this covalently closed circular DNA is transcribed by the help of host RNA polymerase into 5 viral mRNAs, which is further responsible for production of peptides and then hepatitis B virus. So first, this is the pre-genomic RNA, which is complementary to this circular DNA. It further it transcribes into the pre-genomic DNA by the help of reverse transcriptase. The pre-S2 and pre-S1 mRNA are responsible for production of the hepatitis B surface antigens. Pre-genomic RNA, it is complementary to this closed covalently circular DNA and it forms the HBV DNA, and this pre-core RNA is responsible for formation of HBe antigen. So this is the life cycle of hepatitis B virus. The virus is then released outside the hepatocyte. Along with this, subviral particles are also released, which does not contain the nucleocapsid. It contains only the HPS surface antigen, which are filamentous and the spherical forms. And HPE antigen is also released into the circulation. HPE antigen is a marker of replication. So when it is released, that means the virus is replicating. And we cannot detect core antigen in the circulation as it is not released into the circulation, it is inside the capsid. So in in we can only detect HPS antigen and HBe antigen. Now serological markers in hepatitis B, there are, first there is HPS antigen, which is used as general marker of infection. Then antibody to HPS antigen is anti-HPS. It is a protective antibody. It is used to document recovery or immunity to HPV infection. Then anti-HPC IgM, this is the antibody against the core antigen. It is a marker of acute infection. HPE antigen, it indicates acute replication of the virus and therefore infectiveness. Anti-HPE, it is the antibody against HPE antigen. It means that virus is no longer replicating. However, individual can still be positive for HPS antigen, which is made by integrated HPV. HPV DNA, it indicates active replication of the virus. Um, it indicates the active replication of the virus, and it is used to monitor the response to therapy. Now I will further go into each serological marker details. First, the hepatitis B surface antigen. Its presence indicates that a person has HBV infection and it is infectious. It is the first marker to appear in an acute infection after the elevated liver enzymes. The disappearance after 2 to 6 months indicates recovery from infection. If it persists after 6 months without generation of HBsAg antibody, it indicates chronic infection carrier state, and it can be used to diagnose an acute or a chronic infection. Now HBe antigen, it appears after HBsAg but before symptoms. Its presence indicates uh, active viral replication and high infectivity. It is the marker of acute HBV replication and of infectivity. However, the absence of HBeAg in a person who is HBsAg positive, it does not imply that the individual is not infectious, as it can there be in pre-core or HBeAg negative mutants. It can be used to monitor therapy of patients with chronic HBV. Now, anti-HBe antibody. it appears as HBeAg disappears. It implies that hepatitis B virus is no longer replicating and the disease is resolving. In chronic hepatitis B infection, a positive result indicates resolving or response to therapy or minimal liver disease. However, individuals who are HBsAg positive and have anti-HBe present must still be considered infected. Now, IgM antibody to hepatitis B core antigen. It is primarily used if there is a high index of suspicion to indicate that the patient is in early convalescence or window period. It occurs when HBsAg has disappeared and anti-HBs levels are not yet detectable. So this is called window period, where we can detect IgM antibody against the hepatitis B core antigen. Positive result usually indicates hepatitis B virus infection within the preceding 4 to 6 months. It appears after HBsAg and it is usually detectable for 3 to 12 months, and then it is replaced by IgG anti-HBc. Now, antibody to hepatitis B surface antigen. It is a protective antibody. It appears weeks to months after HBsAg disappears, and its presence indicates resolution and immunity against HPV infection or response to vaccination. And levels greater than 10 international units per liter are usually considered protective. So this is a diagram, serological profile of acute HPV infection. So first, if infection happens, then 2 weeks to 3 months after that, HPsAg will appear. This is the first marker of infection, and it means that the person has been infected. After HPsAg, HBe antigen will appear. It indicates active viral replication. It indicates that the virus is actively replicating. After HPsAg, levels will fall down, and then when if the virus is infection is resolving, then anti-HPs, the antibody against the surface antigen, will appear. Then the antibody against the core antibody will appear. In the starting, it is usually of IgM type, and when IgM levels decreases, the IgG, the total levels, it will rise and it will remain persistent throughout. After, when the infection is in resolving phase, the antibody against the HBe antigen will appear. When HBe antigen level decreases, the antibody against the HBe antigen will appear. There is a phase when HBs antigen levels decreases, it is not detectable, and anti-H the antibody against the surface antigen levels are also not detected. So in this phase, this is called the window period, where we can detect antibody against the core antigen, which is anti-HBc IgM, can be detected. So acute hepatitis B infection. In acute infection, there is detection of HPV DNA, hepatitis B surface antigen, HBeAg, and IgM antibody against the core antigen. So 1 to 10 weeks after exposure, this IgM is replaced by IgG, and it persists for life in decreasing titers. So the usual recovery sequence, it begins with the loss of replicative markers. First, HBeAg and HBV DNA, there is seroconversion to anti-HBe and disappearance of HBs antigen. Return of the liver function test, ALT levels to normal, and then appearance of anti-HBs, which means that the person is resolving. There is immunity to reinfection. This is a diagram showing acute hepatitis B infection. So the first marker of infection is HBs antigen, which levels rises. Then HBe antigen level rises. Then after when it is resolving, when there is disappearance of HBs antigen, the antibody against surface antigen will appear, which means there is immunity to reinfection. There is IgM level will rise first, and then IgG levels against the core body, it will remain persistent throughout in decreasing titers. Now, chronic hepatitis B infection. The hepatitis B infection chronic is divided into four phases, taking into account the presence of HBe antigen, HBV DNA levels, the ALT values, and eventually the presence or absence of liver inflammation. The risk of progression to cirrhosis and HCC is variable and it is affected by host immune response. So, stages of hepatitis B infection. Now, stages of hepatitis B infection. There are four stages. Stages of hepatitis B infection. There are four stages: immune tolerance, immune clearance, immune control, and immune escape. In neonates, there is a 90% chance that it will progress to chronic hepatitis B, and in adults, it is 5% chance. In neonates, because of immune tolerance, there is risk of chronic hepatitis B infection. As hepatitis B does not have a direct cytopathic effect on the hepatocytes. It is because of the immune response, there is clearance, there is killing of the infected hepatocytes because of the immune response, which leads to the necrosis of hepatocytes and abnormal LFTs. So, in neonates, because of the high viral load and because immunity is not developed, so the ALT values are normal and there is HB antigen is positive. So, we have to monitor every 6 to 12 months. So after some time, after first or second decade of life, when there is immunity, when there is high viral loads, HBV DNA, then the there will be abnormal LFTs. HBe antigen will be positive, and there can be risk to cirrhosis and HCC, hepatocellular carcinoma. Therefore, they should be referred for treatment. Now, this is immune control phase where there is low viral load. LFTs are normal, HPE antigen is negative, there is presence of anti-HPE is positive. So we have to monitor every 6 to 12 months. In immune escape phase, now again there is high HPV DNA. So there are abnormal LFT, their HB antigen is negative and anti-HBe is positive. So they are at risk of progression to cirrhosis and HCC. Therefore, they should be referred for consideration of treatment. So we have to treat this immune clearance and immune escape phase. Now, this is an image showing chronic hepatitis. As discussed, this HBs antigen remains persistent and the total anti-HBC, it remains persistent throughout life. There is no appearance of anti-HBs AG in these patients. Now, this is the summary of all what we have discussed. So, when HBs AG is negative, anti-HBC is negative, anti-HBs is negative, all are negative. So, there is no hepatitis B infection. That means that person is susceptible to infection. Now, in this case, HBs AG is negative, the anti-HBC, the core antibody is positive, and anti-HBs is positive. So it means that it is immune due to natural infection. Anti-HBs is positive. That means it is in resolving phase. It has immunity against reinfection. So it is immune due to natural infection. And natural infection, anti-HBC is positive. That means that the person has been infected. In comparison, when the person has an hepatitis B vaccination. So in this case, anti-HBs will be positive and anti-HBC, the core will be negative. So that means the person is not infected. It is immunity due to hepatitis B vaccination. Now, if it is acutely infected, so HBsAg will be positive as it is acute infection. Anti-HBC will be positive. Anti-HBC IgM will be positive. That means it is acutely infected. And anti-HBs is negative. In chronically infected, HPS-AG will be positive. In chronic infection, if levels does not goes down, the core antibody will be positive, IgM will be negative, IgG will be positive. That means it is chronically infected, and anti-HBs will be negative. Now, if we have a case where HBsAg is negative, the core is positive and HBs is negative. So only there is isolated core is positive in a patient. So there could be four possibilities. It can be a resolved infection, most common. It can be a false positive anti-HBC. So it can be false positive, that means the person is susceptible. It can be a low level chronic infection or a resolving acute infection. So this is a diagram which is showing isolated core positive in window period. That means when HBsAg levels goes down and anti-HBs has not appeared till now, levels are undetectable. So we will have isolated core antibody positive. That means the person is in window period. This is a diagram showing in this person only anti-HBs is detected. That means this is example of a hepatitis B vaccination. The core will not be the core will be negative in this patient, in this person, as it is due to hepatitis B vaccine. Now, estimated risk of transfusion acquired hepatitis B prior to HBsAg screening of blood in 1971, it was estimated that the risk of transfusion transmitted HBV infection was 6% of all multiple transfused patients, and after the introduction of HBsAg screening, the risk was reduced to approximately zero point 0.3 to 1.7%, and there was 70% reduction was seen in incidence of total post-transfusion hepatitis and 85% reduction in post-transfusion hepatitis. Now, mutations in hepatitis B virus. This the hepatitis B virus viral polymerase, it lacks proofreading activity, resulting in an estimated error rate of 10 raised to 4 to 10 raised to power 5 nucleotide substitutions per site. The most common and clinically relevant mutants, they affect the pre-core core promoter, pre-S mutants, and the polymerase genes. The HPV S gene mutants, they have been described in infants infected with HPV despite an adequate anti-HBs response to HPV vaccination. These are vaccine escape mutants. Now, occult hepatitis B infection. Occult hepatitis B infection, it is defined by the presence of HPV DNA in blood or liver tissues without detectable hepatitis B surface antigen. It is further classified as seropositive or seronegative. Seropositive is individuals who are positive for anti-HPC, and seronegatives, they are negative for both anti-HPC and anti-HPS. Characteristics are there is low level of HPV DNA which is present in blood and liver tissues, and majority of these cases they have variation in genomes, so that as those it cannot be expressed on envelope proteins or produce S proteins with aberrant epitope. Now it is found in recovery from past infection, which is defined by the presence of anti-HPS. Chronic hepatitis, where the infection is related to escape mutants that are not recognized by either natural polyclonal or monoclonal antibodies in assays. Chronic hepatitis at the healthy carrier stage, where the level of HBsAg is too low to be detected. It is identified by the presence of anti-HBC or with or without detectable antibody to hepatitis B E antigen, or chronic hepatitis or healthy carrier without any marker of HPV infection other than the HPV DNA.